Hi, everyone, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. I'm Kevin Poe, founder and editor of Kevin MD. Today, we have Dr. Ajit Ray. He is an anesthesiologist, interventional pain specialist, medical ethicist, and humanitarian aid worker who has provided medical care all over the world. He most recently left his practice in California for New York City to provide disaster relief in the global epicenter of the COVID-19 pandemic. And almost as important as that, he is a Kevin MD contributor. And before we get into that, I am fascinated by your story. And I want you to share a little bit about your journey to where you are today.
Thanks for having me, Kevin. I was born and raised in the Bay Area of California. I did my medical training in Los Angeles, medical school and residency. I did my fellowship training in New York City. And because of that, I've always had a special place in my heart for New York City. So when the COVID pandemic kind of blossomed in the epicenter, which is New York, I felt a strong calling to come back and help. And that's where I am currently. So I'm talking to you from a hotel room where I've been living for the last 8 weeks to provide disaster relief. Before I started private practice and right after I finished my all my training, I left the US for a few months and I did Doctors Without Borders. So I was living in the Middle East, taking care of war-wounded refugees from Syria, Iraq, Palestine, and Yemen. And I helped build a pain management program for some of these war-wounded veterans and refugees. And after that, I started private practice in California, and then I was doing that for a few months. But then this pandemic hit New York City, and I rushed back here, and I got emergency credentialing at my former hospital in Manhattan, along with a few other hospitals. So I have been staffing COVID intensive care units along with emergency response teams throughout the city.
Well, that's fantastic. And we're filming this at Memorial Day weekend. So tell me, how are things on the ground now?
Things are a lot better than they were. So social distancing certainly works. And that's one very reassuring thing about our overall global strategy. The patient volume is tremendously lower compared to what I saw 8 weeks ago. I mean, 8 weeks ago, you were swimming in patients. The emergency room hallways were intensive care units. The hospital administrators' offices were intensive care suites. You had prone patients in every other room of the hospital. So it really felt like a war zone. Mm-hmm. But progressively, as time went on, our volumes started to slowly normalize, and then repurposed intensive care units got converted back to their original purpose. So now the hospital is looking more normal, and I would say that now we're under capacity, and we are slowly starting to reopen things like elective surgery, for instance.
And how's the situation with personal protective equipment?
So, the governor says that about 2 weeks ago, he said that the PPE supply had finally normalized. Mm-hmm. However, on the front lines, I can't always agree with that, because I think I have residents who still every day, I come to an emergency and they're not wearing PPE. And when I query them about why they're not wearing the appropriate masks or caps or gowns, they say they don't have access to it. So I don't think it's perfect. And maybe the supply is better, but I believe there's probably a distribution problem, because there are administrators who may have too tight of a hold on PPE, and they don't necessarily know how to distribute it responsibly. Nevertheless, to circle back to your question, I think PPE remains an issue.
Now, is it only specific to your particular institution, or do you find that most of the institutions in New York City are undergoing the same conditions?
So I've been helping at multiple hospitals in the city. So there are some hospitals who are very well equipped. And to give you an example, when I first started, when we were surging and we were peaking in volume, I had one N95 mask per week.
Wow.
Fast forward to today, we have access now to, at this specific hospital that I'm referring to, at that same hospital, now we have access to 5 N95s a day.
Okay.
So, but that's one particular hospital. Now, once again, I'm providing care at a few different places, and some of the other hospitals, the distribution is not as robust.
So I want to circle back to your first Kevin MD article that you wrote at the end of April, and it was titled "Young Physicians Belong on the Battlefront." And during the surge, did you find a lot of physicians just uproot themselves from wherever they were practicing and travel to hard-hit pandemic areas like New York City?
There were a lot of providers from all over the country, nurses and doctors. I met people from Florida, also from California, from Idaho, from Arizona, and I don't know that many people who I think stayed for as long as I have, but I would say what was really inspiring is that people from all over the country did as much as they could. And that was in terms of staffing intensive care units if they were ICU physicians, but even people who weren't intensive care trained were filling in wherever they could. I remember working with a dermatologist who was helping with end-of-life conversations with family members, because there was a point in time where we were so slammed and overwhelmed. Taking the time required to have a thorough end-of-life goals of care conversation was just not possible because we were so spread thin. So we needed that backup from someone who understood clinical science and understood the nuances of end of life. And so I remember this dermatologist, even though he wasn't going to intubate anybody, but he filled in and played a very critical role and helped with end of life convos, and that was perfect.
Wonderful. That's pretty inspiring just to see everyone band together like that. So tell me about the thrust of that article. Young physicians belong on the battlefront.
So what we know from the disease course of COVID-19 virus, there is a disproportionate number of older patients who are affected. I mean, we are learning that a lot of age groups are hit by this, but disproportionately, overwhelmingly, it is the older populace that is most affected. Now, if we want to protect our healthcare workforce, we need to protect them as best as possible. So my personal belief is that younger doctors have a greater moral imperative to step up and be on the front lines and be on the battlefront, if you will. So by us thrusting ourselves on the front line, we can protect our older workforce who can then fill in and still provide care to the country, but in a different capacity. Maybe they can fill in telemedicine roles, but leave the high risk stuff to people who can better tolerate the insults of this virus, i.e. the young. I certainly do not mean to dismiss the expertise and wisdom of our older colleagues, but the purpose of my article was really just a call to action for people who were statistically better likely to tolerate this virus.
And have you received any pushback? I've published, as you can imagine, hundreds of articles on my site about the pandemic, and there's a wide range of opinion, as you can imagine. And have you received any pushback from this point of view?
You know, I've actually gotten a lot of support. I haven't experienced a lot of pushback yet. I was expecting some, but no, people have been pretty supportive. And even on the clinical front, when, for instance, as an anesthesiologist, I routinely respond to emergencies when patients are about to die. They need to be put on life support. So they need a ventilator, a breathing tube, they need resuscitation, they need lines. And the way we addressed this was we created these high-risk intubation teams. So it would be typically 2 anesthesiologists. And if I was ever on a team with an older colleague, they were always very receptive and welcoming of my, I think, desire to take on more volume of cases. It's like, look, why don't you hang out and why don't I take this? Because, you know, it is a very high risk exposure event. And if I have the ability and capacity to do that procedure, I believe it should be me. And for the most part, my colleagues were pretty welcoming of that. And to further comment on that, I've been working at a hospital that was aggressively hit by COVID to the point where a large portion of the anesthesiologist workforce fell ill and they were out of work. So you can imagine how troublesome that is when an essential service line gets wiped out and everyone needs to be put on life support, and you don't have this service line. So this hospital in particular was very sensitive to the fact of like how high risk of a specialty it was. So they were much more welcoming to my volunteering to be there.
So you mentioned that you're winding down your New York deployment shortly. And as I mentioned before, we are filming this on Memorial Day weekend, and a lot of the country is opening up, and you did write an article on that. So I just want to get your general opinion in terms of how things are going.
Yeah, so the fact that the country is reopening, I certainly understand the desire to reopen, but I'm pretty apprehensive about a lot of the plans that are being employed nationally. The CDC unveiled very strict gating criteria and a phased reopening plan, and so did the White House. However, a lot of these expert opinions from the CDC, for instance, they constantly are reporting that they feel like they're being muzzled, they feel like they're being silenced. And a lot of that stems from this belief that we have 2 conflicting priorities. One is public health and the other is economic revival. My personal belief is that we can actually have both. And if you go back to the 1918 Spanish flu and you looked at the reopening policies of a variety of cities throughout the US, you'd actually find that the regions that had the strictest reopen policies and the regions that were most aggressive about their shutdown measures, they actually responded better economically, and they bounced back faster and more robustly than the regions who had softer shutdown measures. So that's evidence from the 1918 Spanish flu pandemic. Also, we can look at Sweden. Sweden is infamous now for not doing any sort of lockdown. They kept everything open: shops, churches, salons, restaurants. And the Swedish government simply said, hey, we trust our citizens to use common sense social distancing guidelines. However, their GDP is still projected to plummet this year. And compared to other countries, the finance minister and a bunch of other economists in Sweden, they still project being hit very hard financially and on par with a lot of their neighboring countries. And that didn't come without a price. More than, I would say, 30% of more Swedes died this year compared to years past. So they lost a lot more life, and their economy has not been preserved.
Sure. Now, what would you change? So right now we have, to say the least, a disorganized approach when it comes to reopening. It's almost like every state for itself. So if you were in charge, what would you do differently?
I do recognize that every region has their own nuances. You know, reopening New York City, you can't do the same thing that you would do in Idaho because population density, the reliance on public transit, the sheer volume of people, um, so the policies that you would employ in a New York City are fundamentally different than what you would
Mhm.
employ in a Phoenix, Arizona. That said, I think we have to look at very, very key objective virus metrics. Number
Mhm.
one, we have to look at ICU utilization. We have to look at case incidence trends. We have to look at PPE volume, PPE supply chains. Bottom line, there are a number of objective virus
Mhm.
metrics that have to be carefully evaluated prior to reopening. And I'll give you an example. Alabama right now, they had very loose shutdown measures
Yeah.
and they were pretty aggressive about reopening. And right now they are projected to potentially be on par with New York City because, sorry, I should say that Alabama is experiencing an ICU that's over, or ICUs that are over capacity,
Yeah.
similar to what we experience in New York. And I think we should, as a nation, get ready for a number of surges all over the country as reopen patterns continue. And that actually points back to my initial article that as we continue to open, as the curve flattens in one region, it's going to be spiking somewhere else. So
Mhm.
as the curve is now flattened in New York, it's peaking in Alabama. And I believe that young, less attached physicians should be prepared to mobilize to these surge cities and provide care where it's needed the most.
Now, what are your plans going forward? You mentioned that your deployment in New York City is ending shortly. So, what are your next steps?
Um, it's that's a complicated question because so I do a lot of international work too
Mhm.
with Doctors Without Borders, and Brazil is projected to be a very hard hit region that could be the next epicenter. Um, Yemen is getting hit very hard also. Uh, so I have a lot of desire to contribute internationally, but at the same time, because of international travel restrictions, what's happening on the humanitarian aid front is that a lot of these humanitarian aid organizations, they can get you to one of these hard hit regions, but they may not have a promised plan to get you back on time. So
Mhm.
you might just be floating in Brazil for a while. And um, so I have an interest to continue international humanitarian aid wherever the next epicenter might be. But for the time being, until travel restrictions are a little bit more fine tuned, I think I want to continue providing care in the US wherever it's needed the most. So I might be bouncing around the country and chasing this virus around for a bit.
Right. Now, over the last 3 months, I know a lot has happened. What's something that's surprised you over the last few months?
One thing that I think has surprised me, but also inspired me, is how resourceful the medical community is internationally. We collaborate with physicians from France, from Italy, from Wuhan in real time. And the ability to share knowledge and data and studies that have occurred in Italy, and we get to employ those practices and those findings here in New York City. And then um, I think that resourcefulness is something that's really fantastic and has showed just how much the medical community can come together in times of need. And for me, being here in New York, I routinely video conference with my colleagues in California
Mhm.
to help share best practices, because what we're experiencing here is, it's, although it's different, a lot of the lessons can be employed in terms of preparation. But overall, to answer your question, the resourcefulness of the medical community
Well,
is very inspiring.
well, that's wonderful to hear. And my final question, what's the take-home message that you have for my audience?
The take-home message that I have for providers, for doctors, for nurses, is I believe that we have spent our entire lives training and learning a very, very critical skill, and that is how to help save lives and how to enhance the health of our communities. And no, these skills have never ever been more critical than right now.
Mhm.
So even if that means us temporarily uprooting for a period of time to help regions in need, I think we need to be prepared to make those sacrifices because we have such rare skills that are so overwhelmingly in need right now. And I just want to, you know, encourage other providers to be ready and available, to be a little bit more flexible than they previously ever had to be. And if that means we need you in Alabama in a few weeks, or if we need you in Arkansas in a few weeks, hopefully you'll hear the call and you'll make arrangements to come.
Ajit, thank you so much for sharing your story and your journey. Thank you for doing what you're doing, and best of luck to you in the future.
Thanks a bunch, Kevin.
All right, take care. Bye.